Diabetes surgery has been in news for last 2.5 months, and there's been much discussion about this in media and in medical fraternity alike. There have been many speculations, doubts, and appreciation of what we have introduced. There have also been some criticism that this surgery is nothing new. It's a type of bariatric surgery. So I thought it's the right time that we discuss the evidence that supports why surgery is considered the most effective therapy for diabetes. And so I'll start my presentation, and at the end, I'll be very happy to take questions. You can share questions with Doc Plexus and Dr. Shithil, who is moderating this program, will be asking those questions to me, and I'll make sure that every question is answered. So give me a second. Let me start my screen share. So friends, greetings from Center for Metabolic Surgery, which is at Wockhardt Hospital, Mumbai Central. And the topic of the day is diabetes surgery, what in scientific term is also called metabolic surgery. I am director of their program at Wockhardt Hospital. I am also founder editor of Journal of Bariatric Surgery in India, from India, and I've been president of IAGS. Now, as you can see, the diabetes surgery terms arises from metabolic surgery. Why we cannot use this bariatric term is because bariatric applies for baros for weight, and the term applies for treatment of obesity. And bariatric is the scientific term, and it's used popularly as obesity surgery. Even the journal which is published for bariatric surgery is called Obesity Surgery Journal. So when it came to treatment of diabetes through metabolic surgery, the layman term has to be diabetes surgery, and that's how this term was coined and is being popular now. Diabetes, as you all are aware, is a very common disease. It's a major problem. Almost 8 crore Indians have diabetes, and almost 77.6% of them remain uncontrolled, despite taking medicines, lifestyle measures, and all education that goes with it. Now, the problem is not the raised sugar, but if the raised sugars remain for a long time, then there is a likelihood of having more complications. And we all know that neuropathy, retinopathies, cardiac problems, renal problems, brain strokes, etc., etc. The cost of diabetes management, along with its complications, is almost $31 billion as documented in 2017. And it is also said that diabetes alone exhausts up to 25% of average household earning in a year. So I think it's very important to realize that diabetes is a major problem. Like many other diseases, like cancers, like cardiac disease, now surgery is also one of the treatment options. Like in cardiac disease, coronary bypass graft surgeries or angioplasties is one option, while the medicines still remain. Similarly, now diabetes has another treatment option besides medical management and lifestyle changes. And I'm going to talk to you in next 15-20 minutes about that. So what is diabetes surgery? A lot of people said that, diabetes surgery is nothing else but bariatric surgery. Absolutely correct. This is bariatric surgery. So surgically, the surgical technique is the same as bariatric surgery, but something has changed over the last 3 months, and that's why we are discussing this today. So what has changed? Now we are able to offer this surgery only for diabetes, even in patients who are not obese. So the guidelines that have changed as recently as this publication in December 22, about 2.5 months back, the guidelines changed that for Asians with BMI 27.5, we can offer this surgery for uncontrolled diabetes. Now, realize the implication of this. Up till now, we knew that bariatric surgery can be done for obesity. And obviously, some of those obese people also had diabetes, so they benefited from it. Now, first time in last 30 years, or let's say centuries, we are in a situation where it is said by international guidelines that we can offer this surgery only for diabetes. So if a patient with 28 BMI comes to my clinic and says, Dr. Goel, I'm not very happy with my weight, please do a bariatric surgery, I will have to refuse because the lowest BMI for obesity is 30 for bariatric surgery. But if the same person at 28 BMI comes with an uncontrolled diabetes despite medical management, I can offer the same surgery for diabetes management. So friends, it's important to realize that the difference is that now this surgery, which was earlier called bariatric surgery, can be offered exclusively for diabetes. Anybody above 27.5 BMI, whatever is the BMI, if he has a diabetes, uncontrolled diabetes, we can offer this surgery. So this has changed. And this has not changed overnight. In 2011, International Diabetes Federation published a paper in Diabetes Care where they said that this surgery should be offered in Asian patients with 27.5 BMI because we are at very high risk of diabetes-related complications at low weight. Nothing changed after that. We continued to offer it above 35 BMI. Then American Diabetes Association in 2021, I put the publications here. 2021 Diabetes Care mentioned that the surgery can be offered for Asian Americans if their BMI is 27.5. For non-Asian American, it was still 30 BMI. It still is 30 BMI. But for Asian Americans, it can be offered at 27.5 BMI. Same thing is also followed in UK. If a patient goes through for 28 BMI or 27.5 BMI with uncontrolled diabetes to NHS, they will do the same surgery. They will offer the surgery. But if a Caucasian British person goes to NHS with 28 BMI, he will not be given this surgery. He will only be given this surgery above 30 BMI. So I think these were the two medical associations, largest associations worldwide, which endorsed this in 2011 and 2021. But still, surgeons were not doing this surgery, and we waited till the guidelines changed internationally in December 22, which is only about 2.5 months back. Another thing that we need to realize as physicians is that diabetes remission has been defined, and diabetes remission is if the patient is not taking any medicines for diabetes and is maintaining his HbA1c below 6.5 for at least 1 year, then it is partial remission. And if the same person is maintaining HbA1c below 6 without medicine, then it is called complete remission. Now, this is generally not possible with medicines. Remission is not possible with medicine generally, because if by medicines you bring down the HbA1c below 6, then the condition of remission is that they need to stop the medicine for at least 1 year and still maintain HbA1c below 6, which is not possible. So remission only is possible, generally speaking, after a surgery. And I'm going to mention to these definitions repeatedly during my presentation, so please keep a watch. Now, what happens after surgery? After diabetes surgery, 80% of patients have complete resolution. That means their sugars are normal without medicines, even after 1 to 2 years of surgery. And 36% of these patients will remain off medicine even 10 years after surgery. That means if 1 in 3 patients who will undergo surgery for diabetes, even after 10 years, almost 36% of them will not require medicine. And obviously they don't require medicines because the sugars are normal. Nobody will stop medicines if sugars are raised. So I think this is the kind of difference. On one side, we are looking at 77% of patients who will remain uncontrolled with medication. On other side, we are looking at almost 1/3 of the patients, even after 10 years, will remain remain very well controlled and off medicine, while 80% at 1 year will remain off medicine or very well controlled. Now, we have published our own data on diabetes remission. So look at this. The first study that we published, which was 3 years follow-ups of our patients, and we have shown that 80% of sleeve gastrectomy patients will remain off medicine even after 3 years. And almost 92% of diabetes patients will remain off medicine even after 3 years. The same patient set was followed and published after 5 years, after another 2 years. And this sleeve patients, 64% of them are still off medicine 5 years later. Okay. And then we followed up another study of the same group at 7 years. We are now collecting data of 10 years follow-up, which will hopefully publish very soon. At 7 years, it shows that 32% of patients are off medicine and HbA1c below 6. And another 22.6% patients are HbA1c below 6.5 without medicine. If we join these two groups, you will realize 55% of the patients, even after 7 years, are HbA1c below 6.5 without medicines, which is substantially good. And another 13% patients are maintaining HbA1c below 6.5 with medicine. So if we join this, 68% patients, even 7 years after surgery, are maintaining HbA1c below 6.5. And this is what we need to realize the difference, because we are ultimately treating patients. Ultimately, we need to see what treatment helps a patient. It's not a question of who is treating, whether a physician or a surgeon. But if those patients who are not doing very well with medical management and lifestyle changes, surgical help can be sought and offered to your patients. So the question came, this will not work in slim patients. I got a WhatsApp message from a physician saying he has been told that this will not work in non-obese patients. So let me share some data with you. So this study, which came from Cleveland Clinic, had said that those, when they compared the high BMI and low BMI patients, they said the impact of surgery is same in patients, whether they are high BMI or low BMI. This study, which is published by Dr. Shah from Pune, says that there is substantial improvement in those patients below 35 BMI. And then there is a meta-analysis which was published, which says that the benefits of surgery are BMI independent. And this is important, and all the guidelines which I already mentioned support the use of metabolic surgery or diabetes surgery in low BMI patients with poorly controlled diabetes. Now, what is this surgery? I'm sure all of you have attended multiple talks on bariatric surgery. The surgeries are the same, whether it's sleeve gastrectomy, whether it's gastric bypass or mini gastric bypass. And primarily they work by the fact that food reaches the ileum, terminal ileum, faster than in those who don't have the surgery. So whether it's a sleeve, the stomach empties faster and food goes faster, or whether it's one of the gastric bypass, food is reaching the terminal ileum faster. And that is why there are hormonal changes, which I'm going to discuss. Now, as all of you know, these are keyhole surgeries, takes less than 1 hour most of the time. Since it's a laparoscopic surgery, patient can walk and drink 6 hours after surgery, usually 2 nights hospital stay, and they are able to resume work within 4 to 5 days. How does it work for diabetes? Because the food is delivered early in the intestine, there is enhanced secretion of GLP-1 hormone. All of us know GLP-1 hormone, because now this is medically available in the terms of semaglutide and liraglutide, those products. And once the hormone is secreted, hormone works on pancreas and peripherally. It reduces insulin resistance, increases insulin production, and it is also believed to increase number of beta cells in the pancreas. There are other mechanisms also, like change of gut bacteria, calorie restriction. But the very fact that the impact of surgery is seen within 2 to 3 days justifies that it is because of the hormonal changes, and there are multiple studies which have shown the enhanced secretion of GLP-1 after surgery. So friends, is this surgery for everyone? At the moment, the selection criteria with the new guidelines, just 2.5 month guideline, is that the BMI should be more than 27.5, which in layman term, to explain to a patient of yours, that the patient should be around 8 to 10 kgs overweight. So if the patient is more than 8 to 10 kg more than the ideal weight, then maybe we can he or she is a good candidate. Then patient should be on adequate medical treatment. I'm getting patients who have never taken medical treatment, who are on Ayurvedic treatment, or who have never taken medicines, and they want surgery. They don't want surgery. It's little tricky and should not be offered because this is the requirement. And obviously, patient should be safe enough for anesthesia and optimized for anesthesia. Why this is important? Because it has been published somewhere in 2016 that for every year of remission, the risk of microvascular disease reduced by 19% compared to those patients who never had remission. So I think we are talking of remission for 7 years, 10 years, all right? And thus it is important to realize that the risk of microvascular disease will reduce many-fold in these patients. And I'll show you some direct evidence to that effect. Look at this study where they had a group of patients who were managed medically, matched group, managed medically, and another group which was managed after surgery. And they followed these patients for long term. They found out that macrovascular events reduced by almost 75%. In the control group, they continued to in about 9.7% versus post-bariatric group, where it continued in about 2.1% patients. So the myocardial infarction reduced from 1.8% to 0.3%, strokes reduced from 1.6% to 0.4%, and the related deaths reduced from 7.5% to 1.6%. The effect was more drastic on microvascular events, where it reduced by almost 90%. So 2% in control group versus 0.2% in the surgical group. And this is the most, and there are many other publications which have shown its surgery's impact on diabetes complications. And because that happens, and obviously it's a same surgery as diabetes surgery or a bariatric surgery, sorry. So the other benefits like resolution of hypertension, triglyceride reduction, risk of myocardial infarction reduces by almost 50% at around 11 years after surgery. So friends, because of all this, again, another study has shown that 10 years after surgery, there is 40% reduction in all-cause mortality and 56% reduction in mortality due to heart attacks. Now, these are substantial numbers, and based on these kind of evidence, the International Diabetes Federation and the American Diabetes Association have made these recommendations of offering surgery even at 27.5 BMI, even if the person cannot be offered the surgery for weight loss at the same BMI. So now these surgeries are diabetes surgeries. The surgical technique may remain the same, but the indication have completely transformed. And that is why the discussion today. Another study which was published in Lancet has shown that those patients who get this surgery for diabetes, the average life expectancy increases by over 9 years. Now, which other intervention increases the life expectancy by so much? So this goes on to show that diabetes reduces the life expectancy, and if the diabetes is well controlled, the life expectancy is likely to increase substantially in these patients. I am at the end of my presentation. I'll just show you a few patients whom we have operated recently after these guidelines changed. This gentleman, 64-year-old, just 84 kgs, diabetic for 14 years, on OHA and insulin, but still HbA1c was 9.35 and his postprandial sugar was 358. He lives in Mumbai, highly educated person. We did his gastric bypass on 19th of December. He was the first patient to undergo this surgery under the guidelines, new guidelines. His insulin is stopped on day 2, and now he's only on 2 diabetes medication and sugars are normal. I'll show that. This lady who is again 50 years, just 87 kgs, diabetic for 6 years, on 4 drugs, oral hypoglycemic and insulin, 5 drugs, and she's a healthcare worker, a nurse in a BMC hospital, HbA1c of 15, fasting sugar of 240 and postprandial sugar of 454. She had a surgery on 24th December. Her insulin is stopped on day 3 and she's on diabetes medication and her sugars are absolutely normal. She came today to the hospital. Her fasting sugar was 91 and her postprandial sugar was 120. For last 2 months, she has not taken even a single shot of insulin and she's only on oral hypoglycemic. This lady who came from Jharkhand, 53-year-old, 74 kgs, diabetic for 11 years, HbA1c 9.5, fasting sugar 224, postprandial sugar 350. Again, she was on oral hypoglycemic and insulin. Gastric bypass done on 26 December. Insulin is stopped on day 3. She's on metformin and sulfonylurea and sugars are very well controlled. This lady, again 53-year-old, she's a psychologist in Mumbai, 73 kgs, diabetic for only for 1.5 years, HbA1c 7.3. She was on oral hypoglycemic alone and she went for bypass because she read through the literature before coming to us and said that she has read that if you can't get it done early, the possibility of remission is higher. And she got it done, and after surgery, now it's almost about 2 months or 1.5 months. She has not taken a single oral hypoglycemic, and she conveyed to me yesterday that her HbA1c has come down to 6. So these are the kind of results that we see. I'll show you a few graphs. These are all of those 4 patients. These are their fasting sugars. This is 1 month value because, we collated this data in January, and their sugars from 240 to 132, fasting 224 to 129, 184 to 120, 146 to 112. Postprandial sugar 454 to 116, and likewise. All of them had significant drop on their fasting and PP sugars. Now, HbA1c is an average sugar. So when we see it at 1 month, this is also 1 month follow-up. We see 1 month of post-surgical and 2 months of pre-surgical blood sugar. But look at this, the lady from Mumbai who works from BMC, her HbA1c in 1 month dropped from 15 to 10.5. When we will do it at 6 months, then it will be truly reflective of the impact of surgery, and it will be somewhere between 6.5 to 7 if she maintains the post-operative requirement. So, friends, I know there is a lot of skepticism It may be arising out of ignorance of the changed guidelines, but the hardcore data is there. We surgeons, bariatric surgeons, were fully aware of this data for last 15 years, and as it was evolving and getting published. But the guidelines did not allow us to operate these patients under 35 BMI. I did a clinical trial and under the ethical committee approval and published it also, but in low BMI patients, but otherwise in clinical practice, none of us were doing it. Now a time has come that this can be offered to patients in clinical practice, and they can benefit from this. There is one more thing that I want to discuss, since all of you are physicians here. These kind of data brings new understandings of diabetes, new understanding of diabetes management. This is a report of that patient who is a psychologist 1 month after surgery. Look at whose HbA1c is now 6. Her fasting sugar 1 month after surgery was 112, but her PP sugar was 89.7. Now, these patients typically will have lower postprandial sugar compared to the fasting glucose. Why? Because glycemic control now comes with eating. Only when they eat food, GLP-1 is secreted and insulin resistance reduces. And that's why we tell the patients to have frequent meals. So if they were having 3 meals a day earlier, now we say you have 5 to 6 meals a day, because that will bring down sugar even better, lower. And this is important to realize that, a patient who's fasting, whether for hospitalization or for religious reasons, the sugars can go up in these patients. But if patient is normally eating, the sugars will also, if somebody gets hospitalized and kept nil orally, then it's a good idea to check their sugars, that you might find the sugars have gone up. It's also important to realize is that if somebody has an infection in the body, the patient's blood sugar may be normal. Patient may say, I don't have a diabetes, because patients started claiming that they have been cured of diabetes. No doctor, no sensible doctor, whether it's a surgeon or physician, will make such a claim. But patients start believing that. So if somebody has undergone a surgery and says and sugars are normal, and if there's an infection, it's a good idea to check sugar. If sugars are high, anti-diabetic medication can be started till infection is controlled, and you will find the sugars are normal again. Then there is another thing that we realized, that surgery offers a meal size related GLP-1 response. What I mean is, if a person has a smaller meal, obviously the GLP-1 response will be less. If they have larger meals, so that means it's more physiological compared to a fixed dose regime that we have been using on our diabetes patient, whether it's oral or injectable, daily injectable, or once a week injectable. Here we are in a more physiological zone as far as patient is concerned. Now, another question that was asked to me was in last 2.5 months, what happens in long term? How long they will be maintaining their blood sugar? I have already shown data that we have published and international data which says that majority of them will maintain their blood sugar. 1/3 of them, even after 10 years, will not require medicines. They are still in remission. But if you want your patients to maintain blood sugar, ask them to eat meal frequently. I've already explained that. Second thing, the patients come and say, now my diabetes is gone. Can I have sweets every day? Now, just because the surgery has been done, that doesn't give them the license to eat wrong foods. They must continue to maintain their diabetic diet. Now, what is the advantage? The advantage is, if they continue to maintain their diabetic diet, they may remain in remission for a longer period, or they may remain under control without oral hypoglycemic for a longer period. So any sensible patient who understands this will probably follow this and will have better outcomes in long run. As we all know, physical activity reduces insulin resistance. So if the patient is ready to be physically active or do exercises, that will help. And we insist that they must do their HbA1c once in 3 months. So somebody wrote me back, you are saying that diabetes will improve after this. Why you are getting HbA1c done every 3 months? Please realize these patients have been pricking themselves every day to check their blood sugar. Now I'm simply asking them to check it once in 3 months, because in case the glycemia increases, they should know it. They should not remain uncontrolled. They can improve their diabetic diet, or they can take oral hypoglycemic, and that's a. So I think these 4 things, if they are followed, the patients will maintain long term. A lot of patients who have no idea about our history of bariatric surgery, they come and they discuss about the safety of surgery. Please realize this is not a new surgery. Worldwide, it's happening for 60 years. I'm personally doing it for 22 years. And we have been operating on heavy patients like 150, 200, 300 kg patients, which are very challenging. Now, when I'm operating them at 70, 80 kgs, my anesthetists are comfortable. And obviously, there are no guarantees in surgery, but comparatively, it should be they are much more comfort for surgeon. There is published data to say that bariatric surgeries are less risky than gallbladder surgery or a lap cholecystectomy as far as perioperative mortality is concerned. So I think surgical safety is an issue which is discussed always in terms of bariatric and metabolic surgery. But please realize things have changed. I have seen that change in last 22 years. Technology has improved, anesthetists have improved, anesthetic drugs have improved, and post-op recovery has drastically changed in last 25 years. So friends, somebody asked me, how can you offer surgery for a medical disease? I don't think a disease is categorized as medical and surgical disease. A disease is a disease, and it can be managed medically, surgically, or both. I think diabetes is one disease which will require a multidisciplinary management. And what was missing there up till now has been added with these change guidelines in last 2.5 months. Diabetes surgery is certainly not a substitute for medical management and lifestyle changes. And why so? Look at this study, which was a news item in April 2017, which says India has 72 million cases in 2017, which are likely to double by 25. So if this news is correct, and even if every bariatric surgeon, we are about 400 of us in the country, if all of us start performing at least one diabetes surgery a day, we'll probably be doing about 1 lakh of surgery a year. But by the time, the number of new patients which will be added will be almost 10 million. So I do not think surgery can replace medical management or lifestyle management. Surgery cannot manage even 1% of total diabetic load in this country in next 10 years. So this surgery is only for those patients, I keep on emphasizing, who are finding it difficult to manage their diabetes, who have a family history of diabetes complications, early age heart attacks in their parents, or renal failure, or they already have one of 2 complications. So I think it's a good idea to consider this surgery. You may or may not refer a patient to a surgeon, but please look up at your own family members or friends who are uncontrolled diabetes. At least discuss with them, offer them this option, and see that they benefit from this. So friends, to conclude, surgery cannot cure or eradicate diabetes in anybody's body. No surgeon will make a claim like that. Surgery is an effective treatment option for selected patients, as we have discussed. It offers long-term glycemic control. Concurrent medicine stoppage is an additional benefit. Surgery targets glycemic control. Surgery doesn't target medicine stoppage. So when we operate these patients, they are from different cities and different countries. Their physicians will automatically start reducing medicine or stop medicine if sugars are normal. So our purpose, our job as a surgeon is to make sure that the person gets glycemic control. There is significant reduction in diabetes complication and related mortality. There is enough published data, and we can share the data with any one of you, the publications also. But please do not go just by logical thinking or hearsay, because I am getting such kind of messages from all over the country. I have never faced this kind of situation ever in my life in last 35 years of my surgical career, that somebody believes that we are misleading people. We are giving factual information, and the same people have been part of various guideline creation worldwide, and that's why this leads to increased life expectancy. So thank you so much. I have a brief patient's testimonial which I will play out now, and after that I can see Dr. Shithil is already ready with his questions. I'll be very happy to take his questions and answer them. Okay. Dr. Shithil, it says that I have to enter my password to allow this. What password is this? Is this my...
Maybe we can, okay, it's showing right now.
मी स्वतः BMC मध्ये सिस्टर आहे, ॲज अ स्टाफ नर्स म्हणून काम करते. आता जवळजवळ 2 ते 3 वर्ष माझं डायबिटीज खूपच हाय होतं. म्हणजे ॲक्च्युली मी फूडी आहे, मला खाण्याची प्रचंड आवड आहे. वडापाव, समोसा पाव, फ्राईड वस्तूंची पण पहिल्यापासूनच खूप आवड आहे. आणि आता या 2-3 वर्षामध्ये पहिले सुरुवातीला टॅबलेट मॅनेज होत होतो, पण नंतर टॅबलेटचा काही इफेक्टच होईनासा झाला. मग मला माझ्या डायबिटीसच्या डॉक्टरांनी इन्सुलिनवर शिफ्ट केलं.
This lady came to us with a history of diabetes. She's been trying desperately to control her sugars. She's not a lay person. She's a healthcare worker working in a hospital in Mumbai. And she was taking 5 medicines, including the insulin, almost all possible medicines that are available for diabetes. Her fasting sugars were around 240, and after meal sugars were around 400 plus. Her 3-monthly HbA1c was 15, and thus she was really desperate to get the sugars controlled. So we thought that this will be a good patient for surgery. Anybody who is uncontrolled with HbA1c more than 7 is a good patient. So we offered her surgery in last week of December.
सर्जरीच्या आदल्या दिवशी फक्त मला इन्सुलिन दिलं. सर्जरी झाल्यापासून एकही दिवस मी इन्सुलिन घेतलेलं नाहीये. एकदम शुगर नॉर्मल आहे. गोयल सर तर द बेस्ट सर्जन, त्यांच्याबद्दल तर बोलायलाच नकोय काय बाकी. फार छान, मला त्यांच्याकडनं खूप छान एक्सपिरियन्स आलाय. आताशी मला 18 डेज झाले, पण मला पूर्ण कॉन्फिडन्स आहे की बिटवीन 2 ते 3 महिन्यात माझा पूर्ण डायबिटीस जाईल म्हणून. फक्त सरांचं एकच अट असते की ते सांगतात त्याप्रमाणे सगळं फॉलोअप करायचा, आणि त्यांनी सांगितल्याप्रमाणे सगळं डाएट वगैरे व्यवस्थित केलं तर तुमचा डायबिटीस पूर्ण जाईल. आणि माझा विश्वास आहे की जाईल माझा डायबिटीस म्हणून.
3 days later, she went off insulin because her sugars became normal. And then she was discharged from the hospital. And 10 days later, she's only on one medicine, one tablet, one type of tablet daily. And her sugars have come down to 140 fasting and 170 after meals.
वजन पण जवळजवळ आता 18 दिवस झाले सर्जरीला. वजन माझं जवळजवळ 7 ते 8 किलोने कमी झालेलं आहे. मला स्वतःला फ्रेश वाटतं मेन म्हणजे. आता भुकेवर खूप कंट्रोल आहे. चालताना वगैरे पण असं पहिले जरा हेवीनेस वाटायचं, पटकन स्टेप्स चढताना दम लागायचा, उतरताना असं दम लागायचा, ते आता अजिबात नाही. हॉस्पिटलबद्दल सांगायचं झालं तर खूप छान हॉस्पिटल आहे. हॉस्पिटलला ऍडमिट झाल्याच्या नंतर रिलेटिव्हला राहायची सुद्धा गरज नाहीये, एवढ्या छान स्टाफ आहेत सगळ्या. तुमच्याबरोबर नाही नातेवाईक आला तरी काही प्रॉब्लेम नाहीये, तुम्ही एकटे येऊन मॅनेज करू शकता आफ्टर सर्जरी पण आणि इन बिटवीन सर्जरी सुद्धा. माझं स्वतःचं असं पर्सनल मत आहे की ज्यांना माझ्यासारखं सिव्हिअर डायबिटीस आहे त्यांनी खरंच मला ज्यांनी विचारलं त्यांना मी सगळ्यांना एक सर्जरी व्यवस्थित एक्सप्लेन केली. इफ पॉसिबल तुम्ही जर बाकीच्या सगळ्या बाबतीत फिट आहात तर खरोखर करून घ्या.